All right. Well, give folks a few minutes to jump in. If you're calling with us from the East Coast, good afternoon, and other areas of the United States. Good morning. Pleased to have this conversation. We haven't had a Dr. Keys, Dr. Puckrein conversation in a while, so I look forward to hearing the two of them talk about essentially what needs to be done in the health equity movement and what works, doesn't work, what should be done, what's not being done, et cetera, et cetera. So I mean, I don't think any introductions are actually very necessary. We all know Mia, we all know Dr. Puckrein. Just housekeeping if it's your first time joining us. If you have questions, please put them in the Q&A box below you. If you have comments and just want to keep the conversation going and have any tidbits you'd like to share, please put in the chat box. So without a further ado, Mia, I'll turn it over to you.
Thanks, Brandon. And as always, I'm very glad to be sharing this virtual space with my favorite people over at NMQF. And I want to really just open the conversation by saying that I'm so very moved by the leadership the consistent leadership, the cutting edge leadership that you display, Dr. Puckrein, that you and the team, Brandon, just consistently lead with respect to engaging in a scientific way, not only just the moral imperative of equity, but really the efficiency. The reasons why we talk about equity in health is because without equity, we're really existing in an inefficient, less safe, more risk facing healthcare system. And Dr. Puckrein, I know you talk often about what the legacy healthcare system looks like right now in the 21st century, and what we can really get to. The thing about you, Dr. Puckrein, that I love, among so many other things, is that not only are you critical and also engaging in terms of what the data say, in terms of talking to thought leaders across the healthcare continuum, but you're also extremely imaginative and hopeful, which I think sometimes people may not consider for an historian that is really quite, because you are an historian, that is really quite I'd say just an eclectic space to be in, and you pull others in, in terms of having this conversation around equity. So today we're talking about methodological approaches and philosophies to driving the equity imperative, both ethically as well as efficiency with respect to healthcare. So Dr. Puckrein, tell us a bit more about where your mind is at and where NMQF is potentially moving.
Well, first of all, always enjoy having this conversation with you, Mia. You two are bright and imaginative and really committed to the space. So it's always really a joy to have this conversation. We were working on a project and came across two presidential commissions. One in 1952 that was set up by Harry Truman about healthcare and providing health insurance to the American public. And one in 1983, presidential commission that was set up by Jimmy Carter, who was then president. And it too was talking about securing healthcare for the American public, one pre-Medicare and the other one post-Medicare. And it sort of reminded me that there is a sort of intellectual foundation to healthcare in this country. We don't often talk about it. And it gets kind of caught up in the policies that get promulgated and executed, and sometimes we think that those are random things going on, and not really appreciating that they actually are associated with a body of ideas. Someone once told me, if you have a good idea, put it in the journal, and it'll get lost because nobody will ever read it. And so people don't go back the text, if you will, to try to understand how are we provisioning healthcare, and it's not accidental. And so I thought, because we talk so much about equity, and everybody's running around equity this and equity that, and sometimes we're talking about equity in diabetes, and we talk about equity in cardiovascular, and but we haven't taken the time to take a step back and try to understand the, if you will, intellectual foundations. And so it gets a little wonky. But I thought as we move deeper into the 21st century, that we ought to understand, and this is not even legacy now, because these are the principles around which we provision healthcare in the United States. And so at NMQF, we've been working on that, because besides running the data and understanding whether people who have diabetes are getting this medication or that medication, or pushing back on certain policies that we think might have an adverse effect, that we ought to look at the broader framework. We ought to understand, have a little bit deeper understanding, and particularly for all of our friends who are in equity, working on health equity every day, whether they're in business or patient advocacy, or physicians in practice, that you ought to understand that there's a framework. We may not talk about it. So, anyways, let's start off a little bit with Truman. So Truman comes out of the war following FDR, President Roosevelt, who was New Deal, and so he wanted, as part of the New Deal, to have health care insurance for everyone. And so he formed this presidential commission, and they essentially came back and said, healthcare is a right, that we ought to have national health insurance, and understand that in Europe, they had national health insurance all the way back, and really until the turn of the 20th century. So the U.S. as an industrial power was kind of late to the party in terms of providing health insurance to all of the people. What people were doing back then is they would sign up with a hospital and make some monthly payments to the hospital, and when they got sick, the hospital would take care of them. So it's kind of form of private health insurance, but there wasn't any government insurance, and so Truman pushed that, and it got blown up. The American Medical Association took after it. They did not want a national health insurance. They called it socialism, and didn't want the government involved, et cetera. And so the idea of universal health insurance that Truman was pushing, and I encourage you to go Google. You can go Google the 1952 Presidential Commission. You should go read it, because they're making the case that we should have health insurance for all Americans. And understand, when you say health insurance for all Americans, you were talking about everybody, Black and white, Asian, Hispanic, right? At a time when segregation was still pretty much the national norm, and so it was a radical idea that you would provide health insurance to all Americans. Anyway, it really wasn't until Lyndon Johnson came in and got Medicare and Medicaid passed in 65, and part of the reason there was that people were going bankrupt taking care of their parents. Right? Your parents get sick, and what are you going to do? Turn them out, or are you going to pay for their health care? And so he saw this as an opportunity to protect people's wealth, that there would be some insurance for seniors. And then obviously, his Great Society was for poor people as well. And so we had the Medicaid program. So by 1983, those two programs had kicked into space, and the bill was coming due for those two programs. And if you remember, in '83, Jimmy Carter, the economy wasn't going well. There was a lot of pressure on the economy. So he formed this presidential commission, And they came back and said, well, healthcare is not all right. Maybe it's a moral obligation, but it's not a right. And the government, we need to think carefully about that. And the argument that they were making, that's really important for what we now deal with. The argument was there was an unlimited demand for healthcare and a limited ability to meet that demand, meaning a limited financial ability to meet that demand. And so we needed to, they never used the word ration, and I'm not going to use the word ration, I'm going to use the word apportion. We have to apportion healthcare, right? So that because in order to provide everyone healthcare, and here they make the distinction, really important distinction between beneficial care, which they described as the care that you actually needed. And what they were saying is if we provided the care that everyone actually needed, we couldn't afford it. Now, what's also important here to say is that that is a complete and absolute assertion. Right? There was no study, there was no economic model, it was just, and this idea of unlimited demand, limited supply is a very important thing that progressives need to get their brains around, not just in healthcare, but generally we can have a sidebar conversation about that. But in any case, we'll keep ourselves focused on healthcare. And so what they said was, we should provide adequate care. Now, adequate care is less than beneficial care. They're saying that, well, we can't provide care to everyone, but we should provide adequate care. Now, they don't really get deeper into the conversation about what is adequate care beyond saying that no one should experience an excessive burden, though they don't actually tell you what that might mean either. But what the nation should do is provide adequate care. They went on to say that, well, some people have money and some people don't. And since we're never going to get rid of the inequalities in income and resources, people who have money should be allowed to buy the health care that they need. So the gap between adequate care and beneficial care, people could close by paying for it themselves. And the commission goes on to say, and there's no moral obligation that those people who can afford to close that gap should feel that, and that's just the deal. So essentially, what they're proposing is a universal tiered healthcare system. Those who will get adequate care because they can't afford anything else, and those who will have beneficial care by being able to pay for it themselves. And that idea of unlimited demand, limited supply is at the heart of our current healthcare system. So if you think about, let's move it out of government health insurance for a moment. Let's talk about commercial health insurance. Basically, those formularies, those cost shifting that goes on in commercial insurance, all of that is centered around the basic notion that we can't provide quality care, beneficial care, if you will, to everyone. We need to be able to apportion it, and that is the heart of our legacy healthcare system. So when you think of the Medicaid program, for example, they're providing adequate care. They're not necessarily providing beneficial care. When you think of even in the Medicare program itself, there's it's adequate care, and the emphasis is really on financial risk management. And so what you see a lot in our healthcare system is the emphasis on financial risk management. CBO scoring, for example, right, is financial risk management. The Part D formularies is financial risk management. Coverage decision with evidence, financial risk management. The Preventative Service Task Force, financial, I mean, you just go down the list and what you see is this tendency towards managing financial risk. So what does that mean? That means that people who are persistently poor don't get beneficial care. And so the inequities that we see in the healthcare system is really structural, right? And that becomes important because everybody runs around and says, oh, yeah, we want to do equity, we want to do equity, we want to do equity. But the point of the matter is that that's not how the system is built. It's not built to do that. It is really built to apportion care, with some people getting adequate care and some people getting less than beneficial care, and there we are. And so at NMQF, when we look at this, that's why we say that we have to rethink this model if we're actually going to do equity. And so I just think it's important, and hence this conversation, to first establish what is, and being honest about it, right? And because nobody really wants to say to folks, when you go to the healthcare system, it's actually going to elevate your risk because we're not going to give you beneficial care. We're going to give you adequate care. And the minute you do that, you are necessarily going to elevate their risk for a poor outcome because they can get the care that would have been most appropriate for them to receive. So anyway, I'll pause here for a second, but I just, that Presidential Commission of 1983 is really worth reading because you're never going to see a policy or a guideline that references that document and say, here's why we're doing it. But the hard reality is that that's what they're doing. And it also came at a time when the country was desegregating, right? And so it sort of blended in with the sense that they're privileged and they're unprivileged. And guess what? Minority population, because they are facing persistent poverty and inability. But it goes deeper than that because sometimes affluent Blacks and Hispanics think that they can buy themselves beneficial care, but the problem is they're not in the clinical trials. They're not in the data, right? So that you're not, and it's not just limited to minority populations because poor whites get the rural folks, they all get the same deal. And so anyway, I think that's really an important part of the conversation to understand where we are.
What you all don't see, what I'm doing is taking copious notes because this is what I do when I sit at the feet at Dr. Gary Puckrein. And Dr. Puckrein, you've given us much to, I just want to briefly summarize what it is that you've given us so far and then unpack some of this. So we started out talking about the two presidential commissions, one set up by Truman, one set up by Carter, one pre-1965 civil rights movement, Medicaid, Medicare, and then one post, right? And one during New Deal, one was New Deal, one was, around coming out of First World War, that kind of, that time frame. And so much had happened in between. And then you started talking about, the argument which differed from in the 1983 commission was that healthcare was not a right. And in fact, we need to be mindful of of the finite resources, financial resources that the nation has to really attend to what was socialized as something that needed to be apportioned, right? And then we talked about from there the way that our social structures in the healthcare system in particular are really I am going to come back to the legacy, but are really a legacy born out of the tenets that were laid out by that presidential commission. So CVO scoring, you talked about Part D formulary, you talked about USPSTF, you talked about coverage decisions that are evidence-based, but all of these examples are based on a financial risk model.
Yes.
And then you talked about how, and you didn't even really until just now touch on the race, the race part, right? Because you're really talking about how socioeconomic status has truly been the driver between those who are receiving beneficial or full quality care and those who are receiving just enough to leave the hospital, just enough to leave, the space and go back to where they came from, which will likely drive, you're essentially calling it risky to be a recipient of that just adequate care. I want you to please, on top of all of that, help us to think through, what does the racialized experience in the US then, on top of that, what does that mean when we're talking about the beneficial versus adequate care model? Because it is such a unique expression compared to other nations, primarily those, powerful nations that, to your earliest point, which is the US was really slow to the uptake in terms of considering a healthcare model, a national healthcare model.
Not my words, but America's had a caste society really from its birth, right? And the way in which it distributed the gross domestic product, if you will, meant that for minority populations, particularly African Americans, that they did not, nor had they had access to the wealth of the country, the ability to operate in the free marketplace and open businesses wherever they wanted to. I love people who talk about the free enterprise system, right? Because it ain't that free if you're African American or Hispanic. People always tell me, pick yourself up by the bootstrap, and then they come and take the damn bootstraps from you. But in any case, that's a whole other story. But the point is that because the African American population, Hispanics, to a certain extent, even Asians, were consigned to persistent poverty. You don't necessarily have to talk about race to understand how the society's proportioning healthcare by income, because essentially what it's doing is saying that we're going to provide a sort of level of care that might not be the thing that you actually needed, but you can buy your way out of that if you have capacity. And we can make the argument that you can't even really buy yourself out, because that tiered healthcare system means that the kind of investments and knowledge that we need in order to provide real healthcare to everyone gets limited by that. And so when you look at the minority experience, particularly the African American experience, what you see is, because we're doing a lot of work in cancer, so I'm going to use that cancer as a reference point here. So African Americans have the highest incidence of cancer of any population in the United States. Right? Divided it up cohort, we get more cancers. But when you go into our communities, the cancer care is not there, right? That they're medically underserved cancer communities. And if you understand that African Americans live in very specific zip codes, the residents in those zip codes do not get quality cancer care. They don't get the immune therapies and the early diagnosis and all those things that um, um, one should get, particularly if you've got an elevated risk. And so the income issue sort of bleeds over into race and ethnicity, but at its core, it's really about managing financial.
So Dr. Puckrein, and I am going to take audience questions. So I'll repeat, should you have a question, please put your question in the Q&A box below, and any conversation for sure to be mindful of, or you just want to share with people who are on the webinar, put that in the box to the side. Dr. Puckrein, talk to us then about, when you're talking about people, you're talking about NMQF doing equity, right? And working alongside health insurance bodies, working alongside patient advocate organizations, working alongside members of Congress, state and local officials that are driving policy, working alongside healthcare providers themselves. How is it then that they should, in their across this healthcare continuum, think about doing equity when what you've just broken down is not something that can happen because you have a DE&I initiative, right? Or like what is it, ESG initiative or something like that, So let me stop there and then have you answer it, and then I'll follow up.
Well, I think the point is, and this is part of the reason for this conversation. So if you have a DE&I initiative, or if your initiative, and you don't understand the fundamentals of the system, you don't understand how the system is operating, right? What are you actually doing? How do you propose to be successful? What is the framework around which you've built your equity campaign? And and so at NMQF, we think about the health equity movement as having an intellectual framework that presents a counterpoint to the existing system. And where we diverge from the existing system is that we would argue that healthcare is really about managing patient risk. It's not about managing financial risk. And the value proposition has to be, did you keep them out of the hospital? Did you keep them out of the emergency room? Did you keep them from disability? Did you keep them from dying? Did you improve the quality of their life? Those are what healthcare is about at the end of the day. And what we're investing in is our ability to control those events. And so when you apply the financial risk model to that, what happens is you subordinate the patient risk model, because you're setting the priority at managing financial risk. And so the paradigm shift, and that's really what it is to put attention on managing patient risk, and then let us figure out together how do we pay for that, which is the subordinate clause here. It can't be the prime directive of the system. And so what that 1983 commission did was it gave permission to say that if we just gave them adequate care, we've done our job. And it necessarily means that you're going to have inequities. You've built a system that's going to produce inequities, period. It's going to do it, right? And so if you look at sort of the value assessment work that's often being done here, or the comparative effectiveness work, all of those are part of the legacy system. That's why NMQF has such challenges, because when we look at the value assessment models, we say we can't subscribe to that. And the subscription is not that you need to change the model, your fundamental principles are at odds with what people actually need for healthcare. And so that's why we come and say we have to have some methodological principles for the health equity movement, because we have to shift the paradigm. We have to think about this in a very, very different way. And I think that's the challenge in the moment. How do we socialize that? How do we help people understand that providing adequate care? Think about that for a second. You take your child to a hospital and they want to give them adequate care. You take your parents to the hospital and they want to give them adequate care. Or take yourself to the hospital. And you don't know that the system is apportioning that way, nor is it telling you that. And I think that's the challenge.
I do have a follow-up question, but I want to be cognizant about one thing before we move too far. So you mentioned that what really keeps patients or potential patients from receiving beneficial care, particularly if they are racially minoritized peoples, is that clinical trials and other data-driven experiences across the healthcare system are not generally or adequately inclusive of the racialized American experience, right? And so then you can, so can you give us a bit more about that? Can you elaborate about that relationship, and what does then that mean in terms of ensuring that an equity framework reconciles that and moves forward? Because NMQF is doing a lot in the clinical trial space.
Yeah, absolutely. So prior to the Affordable Care Act, many African Americans and Hispanic Americans did not have health insurance. So if you're an innovative company and you're bringing a product to market, right? The folks in those communities can't buy your product. And they can't get it through Medicaid, because Medicaid is not going to do necessarily innovative therapies. And so when you go to construct your clinical trial, you want to produce evidence for those people who are most likely to be able to use your product. On top of that, you don't want to necessarily go into those communities that are completely foreign to you, and you've had all kinds of imaginations about the people in those communities to set up your clinical trials. And so the Affordable Care Act sort of changed that formula and opened the marketplace up a bit. And the demographic shift is having that impact as well, because it's reshaping the American healthcare marketplace. If you take states like California, Texas, New Mexico, Georgia, Florida, New York, Maryland, New Jersey, guess what? They are, if not about to become majority minority communities. And so you now have to open up the marketplace to provide care to those folks. And so right now, we call it the emerging market. That emerging market is being stymied by the old philosophy about the provisioning of healthcare. And so what it means is not fixed. You're going to have a very sick majority population, which is untenable, right? And so the demographic reality is coming into play, even though, and I have to say it because it's incredibly important, most folks don't know this, we've got a lot of folks, billionaires to be blunt about it, who are funding nonprofits to sue in court the idea of providing equity care to minority populations. Because, and they say this, because it disadvantages white people. And there are case law. I mean, there are actually secretaries of state who are pushing this out there because they think that the inequities in the current system are probably okay.
And actually, we're seeing that, you know, particularly in the education system, we're seeing that even in the with the recent lawsuit and determination around affirmative action, but we're seeing that in even the venture capital space, where you know, there's an opponent to that just recently sued. I think it's called the Fearless Fund, which is a venture capital firm, Black owned, women owned, and it's in place to provide seed money for entrepreneurs who are Black or entrepreneurs who are women, many of whom are invested in innovating within the healthcare space, but they're being sued because it's discriminatory. That's the basis of these lawsuits. Yeah, so we see these trends, Dr. Park.
Yeah. We are a multicultural, a multi-ancestral, to be precise, middle class.
Yeah, sorry. Yeah. Oh, sorry. It was muted, but my mistake.
Oh, sorry about that. Can you hear me now?
Hi there, Brandon.
I think he unmuted himself by accident.
Okay.
Yeah. So I mean, there are all these counter trends that are going on that are really important to bear in mind, because sort of refocusing, reimagining the system is not just a matter of presenting the evidence and making the case that you want to make sure that everyone who comes into the healthcare system, regardless of who they are, get adequate care. I mean, beneficial care. There are forces in the society for historic reasons who are very much opposed to that, and so you know, that's part of the work that has to be done. That is not just a walk across the street or just saying here's the evidence, but you also have to advocate and educate, because I would dare say I think our members of Congress and state legislators don't necessarily understand how the system operates, and as they cast their votes, they think they're casting them one way, but actually the system is translating them and doing something quite different.
You know, that's something. So let's stick with that then, Dr. Puckrein. When we are talking about what does policy that is actually based on the tenets of equity, right? And also, I mean, we're using the term equity here, but I hear you talking about justice, which is different from equity in this. They're similar, and they are first cousins for certain, right? But equity refers to giving to, you know, ensuring that everyone has what they need, irrespective of what it looks like compared to someone else, right?
Yeah.
Whereas justice says, yes, we need to ensure that people properly, you know, have what they need in terms of proper care, but we also need to go back and evaluate the systems in the first place and be quite serious about replacing those systems, dismantling those systems. And I'm not talking about in some sort of conspiracy-driven fashion. It's more about what are the mechanisms, what are the pathways to understanding the long-term historical impact of the healthcare system on the way that, to your point now, health is provision, healthcare is apportioned, right? That's a very different conversation.
It is, you know, and
Conversation about power.
Yeah, you raised something really important here that we ought to take a moment on. What is unique about our country is that we have a social contract, right? And when I go back and I look at the writers of the Constitution, the Declaration of Independence, etc., they were social engineers. They were really acute and very smart socially. Now I would disagree with some of the compromises they made in terms of slavery, obviously, and the disaster that it's had on the country was. I think Lincoln would have said as well that was just a terrible decision. But in any case, what our social contract says is that everybody's equal. We hadn't applied it that way, but everybody's equal. And that we come together out of the state of nature to give up some of our freedoms. And in exchange, we commit ourselves together to life. And actually, when Jefferson wrote it in the Declaration, the first draft, it was preservation of life, liberty, and the pursuit of happiness. And so what I would argue is that by our social contract, we committed ourselves to helping each other preserve life, right? And so the 1983 Presidential Commission was out of step with what is our social contract. We don't recognize privilege, right? We're not based on an oligarchy. We're not based on a monarchy. We're based on the idea that everybody is equal and that we work together. Now, we don't guarantee everyone that they're going to be an entrepreneur or a billionaire or that, but what we do is we lean towards the middle class. We prefer the middle class because that's where stability is. That's what the founders would have understood as where stability was, in that we set up our public policy so they lean towards the middle class, and we're not doing that in healthcare, right? We're putting populations at risk. So we have to go back, and it's a chore. It's not going to happen overnight, and maybe even in a generation. But we have to start down that road where we start to look at healthcare and make the investment in it so that we are providing beneficial care to everyone. And I think we can do it. I think we're smart enough to do that. I don't think we need to apportion care so that we have a system that picks winners and losers using money as the arbiter, particularly for life. I don't think that's appropriate at all. So I think that's where the work is, and that's when we talk about methodological principles. Those principles are rooted in the American experience. It's part of the American experiment, if you will, the perfecting that experiment, and also setting our standards so they meet the expectations of the social contract that we all sort of signed up.
Here you go, showing your hopeful threads again, Dr. Puckrein.
We have to be internally hopeful.
We have to be
internally hopeful.
So then, Dr. Puckrein, two questions and follow up to your recent comments. One, where or are you seeing documents that are meant to drive awareness and implementation, or rather I'd say strategies in various healthcare organizations? Are you seeing it in policies, in regulatory bodies? Where, if anywhere, outside of NMQF, are you seeing spaces that are aligning themselves with those earlier documents, which you talked about, irrespective of the fact that those earlier documents weren't completely applied in an equal, in an equal way? And then also, if not, where do you see spaces where they can be, and how can our audience be mindful in holding various spaces accountable?
I just want to point out one point, and then I'm going to answer your question. So part of what happened, certainly for African Americans, in a sense, we became the keepers of the dream, right? Because the freedom, the commitment wasn't given to us It was the work of Frederick Douglass and W.B. Du Bois and Martin Luther King and a whole generation after generation that fought for those principles. And guess what? Out of it, the women's movement came out of it. Religious freedoms came out of it. So a lot of organizations and people benefited by the fact that African Americans had to stay vigilant in terms of pushing the country toward that dream. I think what I would say now is that there's a lot of effort obviously going into equity. There's a lot of resources being spent on equity. There's a lot of discussion and verbalizing about equity. But what's missing is the methodological principles. That's why we're having this conversation, because like any movement, it has to have an intellectual foundation to organize it, to center it, to make the distinction between where we are now and where we want to go. And unfortunately, it gets a little wonky, but some of us have got to go off into the corner and write it down and translate it back out to everyday experience and help our policymakers and legislators. Because I do say, at least in healthcare, I think our policymakers are lost. I think they're hurting the American people and they don't realize it. Or if they realize it, they sweep it under the rug and pretend like it's not happening. But it is happening. The data is very, very clear. So if we go from this to a data-driven conversation, we're going to see the evidence. We have a cure for hepatitis C, but 14,000 people die every year for it because we don't pay for it, right? And there are lots of examples like that where we underinvest in populations and communities. So part of the work that we think about at NMQF, certainly, we want to tackle those immediate disparities in cancer or diabetes in these therapeutic areas. But we also want to lay the intellectual foundation and say, here is our understanding of how this system operates, why it operates the way it does. Here's another way to think about it. And we think that this particular approach will lead to a much stronger America, certainly a much healthier America, and will also help us deal with the inequities that we're all trying to, at least most of us are trying to work.
So Dr. Puckrein, what then do you say to the audience members who are like, okay, well, what's my role in this, right? I'm an academician, I'm a healthcare provider, I'm a state or local official, I'm a student, I'm an industry leader. What do you say to them? For one, I would imagine that you would say that they need to read the commissions, both the Truman Presidential Commission from the 1930s, as well as the Carter Commission from the early 80s. And then I imagine you would probably even say they should read Institute of Medicine's Unequal Treatment, since we're in the 20th year of its production, or of its existence. I'd venture to say I'm putting words in your mouth, but you'll probably say you need to read the Heckler Report. I mean, just all of these documents that over such a long period of time are literally saying the same thing. And how far have we actually come?
Yeah. The first thing I would say, you probably ought to vote, right? Because foundational to our democracy. So part of that social engineering that the founding fathers did was they took power and they dispersed it into the hands of every individual. Now, it may seem like you only got a little tiny fraction of the puzzle here. You may think that your little piece of the puzzle ain't that important, but it is important, right? And you have to, and the idea that they had you would vote your interest, that you would understand what your interest was. Lots of people will come and cloud it up for you, but at the end of the day, you'd be able to sort that out. But then I would agree that you need to measure policy against the commitment that we made in our social contract. Is that really inside a social contract or not? I know people talked about that whole trickle down economics, give all the money to the job creators. Well, that's not in our social contract anywhere. That's not how we thought about it. There's no privilege class among us. I mean, we're all working together towards the same thing. And then certainly um, to read, because to understand the foundations of the system that you're in and how it's moving, I mean, there's a requirement. So it's the 52 was Truman's report when it came out, and 83 was the Presidential Commission of 83 on the Carter. And they're saying two very different things. And really, it's the 83 Commission that seems to have had the most influence on public policy right now.
So we've got just a little under 10 minutes here, Dr. Puckrein. I want to pivot and talk a bit more about the work that NMQF is doing in the space of ensuring that scientific data and healthcare data are reflective of the burgeoning majority minority population. And what does that mean in terms of everything we've just discussed?
So two things I would call them up. First, we have built our own private cloud. We saved up all of our nickels and pennies and dimes, and so in the same way that Azure or AWS have these private clouds, we've built one. And we've taken all the data that we're collecting and we're putting it into that private cloud. And we are harnessing it. We're introducing AI into it because we fundamentally believe that patient advocates have to have access to big data and big data analytics. And we intend to share our data collection and analytical capabilities with patient advocacy groups. It is not a healthy thing that just commercial folks have access to big data analytics and drive it for shareholder value. I'm not against shareholder value. I love shareholder value. It's really a very important part of what we do. In fact, I think healthcare as a business is a great business, particularly if the business is to take care of people. I love that business, absolutely. But we also have the ability to put virtual machines so that we can give organizations the power of the analytics so that they can run their own studies. And so turning ourselves into a huge library and with analytical capabilities. That will start going on stream in October, and we're really excited about that. And it also addressed some of the inconsistent data on minority and underserved populations because we want to go out and study things. African Americans, for example, have the highest hypertension in the world. Ain't one study out there trying to explain why the hell do we have all this damn hypertension, right? And so we get to pick and choose what we want to do. We also do clinical trial work. So we've set up a whole network of clinical trial sites around the country so that we can conduct studies, we can do studies, sponsor studies for folks, but we also want to initiate our own studies where we get to ask try to answer critical questions about what's going on with our population, a broader population, poor, rural, African American, Hispanic, Asians, try to understand where the gaps are, because we're not interested in satisfying shareholders. What we're interested in is managing patient risk. And so if we can learn something that will help a community of folks, we certainly want to do that. And leaning into that, we're part of the president's cancer moonshot. And one of the things I've come to appreciate is that the war on cancer is not going to be over until we're able to bring that science into every American neighborhood. That adequate care is antithetical to the war on cancer, because what it's saying is we don't have to provide beneficial care to everyone with cancer. We can just give them adequate care. And guess what? That's not what the war on cancer is about. And so we are working with the CEO Roundtable on Cancer and a number of other folks to go into communities where they're not getting, where they're getting adequate care, and bring beneficial care to them in terms of diagnostics, as well as therapeutics and other ways, to show that you can actually go into these communities and do it in a financially solid way. And so we've been talking to the payer community, both commercial and public, to say, partner with us. Let's go co-create in the world of cancer. Let's show that we can actually provide beneficial care in these communities and do it cost efficiently and do it in a way that's scalable. And so we're using all of our data capabilities, and we're in communities like Flint, Michigan right now. We're headed into Houston, Texas, into communities where they think they have a cancer cluster, and say, okay, let's go in here and see how we can partner up, bring out. NMQF can't do this on its own, but we say it's part of our social contract. We all have to go here and help our community folks. That's the deal. That's what we all signed up for. That we don't leave anybody on the battlefield. We got to go figure out where they are and go help them. So those are the two major pieces that we're working on right now.
And first of all of that is amazing. And so again, shout out to your leadership and in terms of how you really frame in a way that is not only digestible, but you're also making the business case for evidence-based, equity-based interventions.
Have to have a business case. You're not going to do equity if it don't make business sense. We think equity makes business sense. We think we can document, and we think for too long, people who think that you need to apportion care or disapportion care, however you want to rephrase it, so that you put certain populations at risk, is a workable, usable model. We disagree with it, but we got to go out and prove it. We got to go out and do the hard work, show that you can actually do this, not just assert it, but do it, and that's what we're going to try to do.
What I'm going to do in these last few moments, Dr. Puckrein, is really just, again, encourage audience members to should you have follow-up questions, to engage with Dr. Puckrein through Brandon Garrett or through Ashley Hill, and just ensure that, especially if you're representing organizations that are on the cusp of doing or are at least very interested in hearing more about the work of NMQF and potentially becoming a partner, or at the very least, a deep listening partner. You know, should you feel that maybe the tenets under which your work is driven or your organization's work is driven doesn't necessarily align with what Dr. Puckrein is saying, but perhaps there's interest, at the very least, just come to the table and have a conversation, right? Come to the virtual table as you've done here, or go and see the partners over at NMQF. Dr. Puckrein, any closing remarks for our audience, present and those who are going to watch this in the future?
We live for collaboration. Healthcare is a collaboration. We all work together to keep ourselves healthy, and we invite collaboration and partnership. In fact, all we ever try to do is be a catalyst to say, let's think about this a different way, but let's make sure that at the end of the day, we are taking care of patients. We want to make, and we're all patients or in the moment of becoming a patient. And so that's our goal, is to figure out how do we work together to go into communities and help folks to live good, healthy, long lives. That's just the deal.
Well, Dr. Puckrein, thank you so much for this conversation. You know, for me, this is like better than dinner and a movie. You know, this is.
Well, I always love our conversations being. They really are. Yeah,
for sure.
Absolutely.
Thank you for the accountability, for the homework. You know, we've got two commissions to read. 1950s Commission from Truman, 1980s Commission from Carter's administration. And we've got to think through, the ways that our policies can be reflective of all the tenets you discussed here. NMQF, thank you for holding this, consistent Friday webinar, and for the thoughtful invitation to spend time with some of my favorite folk. I'll turn it back over to Brandon Garrett to close us out.
Thanks a lot, Mia.
Thank you, Dr. Puckrein. I was going to turn it back over to Brandon Garrett. I'll just close this out. You all have a fantastic day. Bye now.
All right, okay, bye-bye.